Hello, my name is Alisha Othieno, and I am a first-year OBGYN resident at the University of California, San Francisco. I am grateful for the opportunity to present my poster abstract, The Impact of Body Mass Index on Interval Cytoreduction and Survival for Advanced Ovarian Cancer. Special thanks to my co-authors, Dr. Blair McNamara and Dr. Jocelyn Chapman. Previous research documents the impact of body mass index on surgical outcomes and postoperative complications, with poorer intraoperative and postoperative outcomes for patients with a higher BMI after interval cytoreduction. There is limited research comparing surgical decision-making, rates of complete resection, and prognosis among BMI groups. In relation to advanced ovarian cancer, the literature also shows that more patients with a higher BMI are chosen for neoadjuvant chemotherapy, and patients who are chosen for neoadjuvant chemotherapy have worse prognoses, leading us to wonder if BMI played a significant role on survival. Our specific aims were to evaluate the survival impact of obesity after interval cytoreduction for advanced epithelial ovarian cancer, and to assess these associations among BMI, route of cytoreductive surgery, and rate of complete removal of macroscopic disease, also known as R0 resection. We performed a retrospective cohort analysis of patients with advanced epithelial ovarian cancer treated with neoadjuvant chemotherapy, followed by interval cytoreductive surgery at a single institution between 2008 to 2018. Patients were included if they were diagnosed with stage 3C or 4 ovarian, tubal, or peritoneal cancer and had full treatment records available at our institution. Our primary outcome of overall survival was compared between patients with a BMI less than 30 versus a BMI greater than or equal to 30, with adjustment for age, stage, and R0 resection using Kaplan-Meier survival analysis and Cox proportional hazards model. Our secondary outcomes of progression-free survival, routes of surgery, and rates of complete margin negative resection were also compared between these BMI groups using logistic regression models controlling for stage. 195 patients were included in the study. 47 had a BMI greater than or equal to 30. 103 patients had stage 3C disease, and 92 patients had stage 4 disease. Patients with a BMI greater than or equal to 30 were more likely to undergo more cycles of neoadjuvant chemotherapy, more cytoreduction via laparoscopy, and complete margin negative resection, although these findings were not statistically significant. The median survival for BMI greater than or equal to 30 versus BMI less than 30 was 55 months and 38.6 months, respectively, and patients with a BMI greater than or equal to 30 were observed to have a higher overall survival after treatment, although not statistically significant. No difference in progression-free survival was observed between the two BMI groups. Although our study did not find a significant impact from BMI on overall survival, our Kaplan-Meier survival curve suggests that patients with a BMI greater than or equal to 30 may see increased survival starting 2 years after interval cytoreduction. Additional research with a larger cohort is necessary to determine statistically significant factors that contributed to these outcomes. Thank you for your time.